already 8 p.m. UK time. I hope all of you can hear me. Just in case, let me know, please. I am your host today again. My name is Caroline. As you can see, our topic is for today, all you need to know about success rates of IVF with donor eggs. We'll hear more about the ways to improve the success rates for the egg donation treatment. And this time we have invited Dr. Pilar Alamá, and she is the director of egg donation program at EV Clinic located in Valencia. Okay, I can see that you can hear me. That's perfect. And of course, let me just tell you a little bit how it's going to work. Dr. Pilar, of course, will start with her presentation, which will last for about 25-30 minutes, and with our Q&A session. And of course, just in case, remember that our webinar is of course recorded. You will be able to watch it online as well. Well, I guess we can start the event. So, Dr. Pilar, are you ready?
Yes, I am.
Okay, perfect.
Yes, I am. Night. Here in Spain it's at 9. Thank you very much for your invitation, trying to share with you and with all patients that in our countries trying to know more about the egg donation successful rate or concerning to the egg donation. It's my first time here in a webinar, so I will try to do my best. And I will try to answer all your questions. And in one moment, we start with my presentation, trying to helping you to know more about the success rates in egg donation. I'm now going to spend a lot of time talking about this treatment, about the egg donation. As you know, there are 3 parts. First of all is the recipient, the partner, who they would like to get pregnant, but we are going to talking about the recipient, is the woman that at the end gets pregnant. The second part, in the other hand, we have the donor. The donor, as you know, in each country has their own regulation concerning to the egg donation treatment, but in our case, in Spain, we are talking about young people who decide to do a IVF treatment to share all these oocytes with another people that without these oocytes couldn't get pregnant. And finally, are the clinics, the IVF clinics, where we do the IVF. We prepare the patient, we prepare the donors, and we finally do the embryo transfer on all procedures considered to the IVF. Only one slide to remark and to focus why the egg donation treatment is so important in Spain, and it's so important for a lot of people. Because as you know, it's the best option for many couples. As you know, people trying to get pregnant now later than before. Our average age in Spain is about 35 years old, the first pregnancy. It means that when the women decide to get pregnant, maybe it's late. Their ovary is not working well. They have failed a lot of times because they decide to get pregnant when they are 40, more or less. As you know, the egg donation treatment is the technique with the best results. We have the best implantation rates, the best pregnancy rates, but it's true that you need to use oocytes from another woman, and maybe for that reason, it's important to be sure that the age is very important. But it's true that it's the technique with the best results. And finally, not in all countries are allowed to do egg donation treatment. For that reason, there's a lot of special things around the egg donation treatment, because it's not easy to decide to do that treatment. It's not too easy to do that treatment in all countries. This slide is only to show you the topics concerning the egg donation treatment in our law. Our Spanish law was approved in 2006, Spain was the first countries in Europe with a specific law concerned to the IVF procedures and concerned to the egg donation. It's very important to remark that aspects. It's anonymous, there are not seeking financial gain, and it's true that donors are paid at the end of the treatment, but about 900, 1,000 euros for each treatment, are not seeking financial gain. The donors are women between 18 and 35 years old, healthy women, and they would like to be a donor, okay? We talk about the screening in 3 slides later, but it's very important to remark that in Spain are the clinics who is the best donor for its partner or who is the best partner for its donor. Okay? The idea is that it's the clinic who decides the best option for each partner. Here in Spain, it's anonymous, and here in Spain, we have a number of cycles that the donors can done in all their lives to be accepted. It means that in Spain, donors could have only 6 children if they can count around children. It means that it's supposed that they can do about 5-6 children in total in all their donor life. Okay? And which are the things that we take into account to do the math to decide who is the best donor for that partner. We take into account all related about the history of both, and we take into account the phenotype characteristics, the blood type, and the genetic aspect we talk about. What is important if we take care about the success in egg donation program? Here we have a list of things that we are important to focus in each one. It's important to be sure the donors and recipient selection criteria. It's important to know the donor about the age. It's important to know the antral follicle count. It's important to know their background, if they have any genetic disease in their family or not, about the screening about infection disease. All these things, it's important. But it's important, in the other hand, to know if the recipient, about the BMA, about the smoking, about the uterus, about these things. Both things are important. It's important what's the way that we do the matching between donor and recipient. It's important, the donor stimulation. We know that doesn't matter what kind of protocol we use for each patient, but if we are using a safe protocol for donor, it's easy for us to have more and more donors and only to have one cycle for one donor, and they decide to avoid a new stimulation because they don't feel very comfortable with that treatment. Important endometrial preparation. Now we are doing a lot of studies to know about the progesterone, because at the beginning we thought that maybe start with progesterone. Doesn't matter the dose. There are clinics with 800. There are clinics with low doses. Progesterone is very important. It's important the day that we start with the progesterone. It's important the dose. And it's important to know the levels of the progesterone the patient has. We talk about that later. There are some discuss about if the fresh oocytes or vitrified oocytes have better or not better results. As you know, EV is a group that have worked a lot with vitrified oocytes. We have a very large bank with vitrified oocytes. And we can say with a lot of information that doesn't matter if we are using fresh oocytes or vitrified oocytes, but there's a problem. The problem is the survival rate. You have oocytes in your table that you have 9 oocytes that at the beginning was frozen, was found without any problem, and you have finally 9 oocytes. The same, you have 9 fresh oocytes, 9 vitrified oocytes. Doesn't matter, the results are the same. The problem is at the beginning that frozen oocytes, you need to thaw them. We talk about that later. What about the number of those that are going to give you? At the beginning, it's important to talk about how many oocytes are given for what partner, one other one. Now the important is the blastocyst rate. Now the important is how many blastocysts are going to give you to be sure that you are going to get pregnant in one attempt or maybe 2 attempts. And at the end, as you know, in the egg donation program, it's very important, a work with a lot of departments trying to work together in the same direction, trying to look for the best donor for each partner and try to use the best option for that patient. It doesn't matter that patients who are living close to the clinic, that patients who are living overseas, that patient that need a specific genetic disease test because their husband has a specific genetic disease. Not all patients are the same, not all treatments are the same, and we try to choose the best option for each patient. What about the donor? This is all the steps that each donor needs to pass to be accepted as a donor finally. And it's important to tell you that about 40% of all women they decide to be a donor, finally they are donor. Because all the exams they need to pass each time are not easy. First of all, the age. They are or they will be between 18 and 35 years old with any illness, capacity to decide they would like to be donor. Okay? Secondly, we need to do a medical history. We ask for them a lot of aspects about their background, about their family, about their children, if they have children. It's mandatory in our law to do a psychological screening by our psychologists, who do a very specific interview with them and try to ask for what is the reason because they would like to be a donor, if they have any fears with the treatment, and what they decide to be a donor, if they will need donor in the future, if they will be a recipient, things like that, that for us is very important to be sure that they realize what are they doing. After that, we do a genetic examination to be sure that there are any illness, any cyst, all it's fine, the number of the antral follicle count, because if we have a donor with lower antral follicle count, in our case, less than 12 between both ovaries, not accept because we think that that patient has a low response. Doesn't matter with low response with young people. We know that there are no problems with the quality of the oocytes, but it's true that maybe in that cases, I share all these oocytes with one partner, and we need to do a new stimulation, and we prefer that that donor use their oocytes with themselves if they need in the future. That with a medical screening, very important, blood type, red, a complete exam to know about all the infection disease screening. In some cases, we ask for some specific illness, biochemical exam, hematological exam, and finally, we do a genetic screening. We do that test in all our donors, both sperm and egg donation. And we do a karyotype. It's not mandatory in our law, but we do always a karyotype, and we always do a karyogenetic test. As you know, it's important because, as you know, about 2% of the children will have a genetic disease that we can avoid if both donor and recipient has done a karyogenetic test. In our cases, we're trying to avoid the match between patients or people that they share the same mutation. So we offer to all our patients a karyogenetic test because we are doing for all our donors a karyogenetic test. All X-linked disease, cystic fibrosis disease are discharged, are not accepted as donor. For that reason, as you say, as you told you before, about 40% of all women that decide to be donor finally are donors. In the way, we lose about 60% of women that they not accept it or they don't pass all these kind of. This slide is only to show you that for us it's very important to look care the donor and trying to do the treatment safer than we know, and to the donor repeat again and trying that the one donor trying to join to our egg donation program feel comfortable, feel good, and decide to come back in the future. For that reason, we always use generate antagonists, we always use antagonists, doesn't matter the kind of gonadotropin that we use, but the idea is trying to avoid the hyperstimulation syndrome in the donor, trying to do the protocol safer that we know trying to be sure that they would like to come back in the future. Maybe for patients, but for the clinic, it's very important that our donor feel good, feel comfortable in our clinic, and feel that we are doing the best thing that we know for stimulation in that case of patient. So if we take into account all these things, the age of the donor, as you know, in Spain, 18, 35, the BMA, I don't tell you before, but in our clinic, we only accept donor between 18 and 28 BMA. If we take into account the age, the BMA of the donor, the study levels of the stimulation, the number of the cycle, is the first cycle or the cycle or 6 cycles, the type of gonadotropins, we know that doesn't matter. These things have no influence on the implantation rates, on the pregnancy rates of the recipient. It is true that there are some studies trying to correlationate the BMA of the recipient and the donor, but in our case that we are using ideal women, young women, slim women, normal women. In that case, if there are no relation, the age, the obesity or non obesity, stradios, the kind of stimulation with the implantation rate. So the most important thing is trying to choose the best donor, but at the end, all these things, nothing is relevant to the implantation rate. What about the recipients? The recipients, we can choose the recipients. Recipients are women that they would like that we help them because they would like to get pregnant. What happened with them? We review the family and personal background. We take into account the risk factor, smoking, overweight, if they have any illness in their ovaries, in the gynecological evaluation about the ovarian activity, if it's easy or not easy to access to the endometrial cavity, because it's very important to do a good embryo transfer without any bleeding, without any pain for the patient. For the reasons we always check once or twice, doesn't matter how many times, the access to the cavity, because it's important to avoid difficult transfer the day of the embryo transfer. For the reason it's very important to be sure that the access is easy. We also take into account the medical screening, blood type, rate, infection disease, the thyroid dysfunction, and prolactin. And finally, genetic screening, karyotype, and current statistics if the partner they would like to do the exam. And in that cases that the women are older than 45 years old, we ask for them, we check that they don't have any problem, and there are some gynecologists who would like to manage this pregnancy. So these are the criteria to select. It is true that we can select the recipient, that to be sure that we are going to helping women get pregnant, but the conditions of that women are healthy women. What about the recipient? It's important the etiology of the fertility to the results. We have done a study 10 years before, and we realized that it doesn't matter if the patient are in the egg donation treatment considering of the age, because they have failed a lot of IVF treatments, ovarian insufficiency, endometriosis, and another etiologic reasons. Doesn't matter. Doesn't matter for the chance to get pregnant. Doesn't matter in the egg donation treatment. What about the age? What about the age? It is true that there are a lot of reports, and there are pregnancy in women older than 50 years. That in Spain is not allowed to do any IVF treatment in women older than 50. Our top is 50 years old, but we analyze our own patients and we divide them into groups: 45 years old, older and younger than 55 years old. And we found differences between 45 years. Women older than 45 years has lower implantation rate, lower pregnancy rates, and they had more problems during the pregnancy. It is true that they have more problems, lower pregnancy, and lower implantation rate, but it is true that it's the only option for that people, for people older than 45 years old, to get pregnant with the egg donation treatment. If they have lower than women younger than 45 years old, it's not a criteria to decide not to do the treatment, but it's mandatory for us to inform that patient that maybe if they decide to do the treatment before, when 43, 42 years old, maybe the result could be better, and if they decide to do the treatment later. But it's not our decision, it's the decision of the patient. But only to share with them that maybe they decide to do the treatment before, it could be better for them. And not for that reason, we are going to avoid helping them to get pregnant. But it's important to realize that. But what about the endometrial preparation? There's a lot of issues. There's a lot of protocols. Depends of the experience of the doctor. Depends of the patient. Depends of the where the patient are living, and depends a lot of things. We are using BT5 oocytes, or we are using fresh oocytes. Depends of them. You have in this slide 2 kinds of protocols, or really it's not 2 kinds. There are 4 kinds of protocols we can use with agonist deposits in the luteal phase before menstruation that we are going to do the treatment, but we can use generate antagonists with the same menstruation. The last treatment maybe could be easier because you only need to do a scan with the menstruation. In the first one, agonist generate agonist, you need to do a scan in the luteal phase and must be sure the doctor that you have a luteal corpus luteum, and if all it's okay, then you can do an injection that it takes 1 month to do the effect. So maybe it could be if you don't have the corpus luteum, you need to do a new in a new day. For the reason could be the antagonist protocol easier for the patient. In all cases, we use estradiol, doesn't matter, part, pills, or vaginal pills, doesn't matter, but you need to use estradiol, and then we start with the progesterone. In our case, we are using 800 micrograms of progesterone vaginal, twice, 400 in the morning and 400 in the afternoon. We have changed recently our protocol, and we start with the progesterone the same day of the donation. And in that case, we try to do the same as the frozen embryo transfer, and for that reason, we decide to start the same day of the donation with the progesterone pills. What about hormonal replacement therapy? There are differences if we use natural cycles or hormonal replacement therapy. There are differences if we are using generate antagonists or generate analogs. There are differences if we are using estradiol, oral, or PAP. There are differences with using the same doses or treatment or increasing doses. There are a lot of studies who say it doesn't matter. It depends on the preferences of the doctor, the preferences of the recipient, their experience with that treatment, so it doesn't matter. We can use whatever you want to be sure that the endometrial gland is growing up. There are another variables that could analyze to be sure that these hormonal replacement therapy are working. We can know about the endometrial thickness, we can know about the estradiol levels, we can know how many days the patient are under treatment. There's a lot of discussion about the endometrial thickness perfect to the egg donation. It is true that there are pregnancies lower than 7 millimeters the endometrial line, but it's true that a lot of authors, a lot of patients, a lot of publications recommended to have more than 7 millimeters in the endometrial line. It means that if a woman never has more than 7, never get pregnant. No, if they have a 3 lower endometrial, could be get pregnant, and there's some medication that could help in that patient to get pregnant. But there's a lot of publication now who are saying that it's better to have more than 7. But if you don't have 7, doesn't matter to get pregnant. Maybe you need more than 1 attempt to get pregnant. For that reason, there are not one line specific to be sure that you accept or you are going to go in with the embryo transfer, and we are not going to follow in with the embryo transfer. What about the progesterone? So now we are doing a lot of work. Dr. Alabarta is working with us in IV Valencia. She analyzed the last year that it's important the dose of the progesterone. More than the dose, is important the levels of the progesterone in the day of the embryo transfer. She realized that if the progesterone level of the endometrial transfer was lower, the one level, the chance to get pregnant was lower, that progesterone levels was higher. For that reason, it's important to know the levels of the progesterone. What's the perfect level between to get pregnant or not get pregnant? We are doing a lot of studies now to be sure which the cutoff for the progesterone level to be sure that patient would be get pregnant easier than the other one. But now we don't know exactly the cutoff for the progesterone levels to trying to improve the pregnancy rate. But now we are studying a lot about that issue. We have done a lot of things concerning to the progesterone, but really we never study it focusing in the progesterone. Now we are doing that, and we can. I don't have all information now because it's we are studying in the studies. We are doing the study, but maybe in 4 or 5 months we will have this information. It could be very useful for the patient because there are patients that need maybe 10 doses of progesterone, but maybe patients with 8 doses they can achieve the cutoff for the progesterone levels that get pregnant. The women that are going to achieve the cutoff doesn't matter. But there are maybe women that they didn't know, but they don't achieve the cutoff for the progesterone. But in that cases, if we give them more progesterone, would helping them to get pregnant. So it's important to focus in the progesterone levels. We are doing a lot of studies to focus in the progesterone levels and how the progesterone change the endometrial pattern, a lot of things. Maybe in future we will have more information to share with you. It's important to the chance to get pregnant. Another topic that's very interesting, and I know that in a lot of webinars and a lot on chats, people discuss about the fresh or vitrified egg donation. It is true that if you are using both fresh or thawing oocytes, the result is the same. The problem is maybe there are some patients, some donors, and when we are using the vitrified oocytes, these oocytes doesn't have a good survival rate. In that case, you at the beginning start with, for example, 12 vitrified oocytes, but at the end you have 6. In that case, maybe the results are not the same if you are using 12 oocytes in the fresh or in the fresh cycles. But at the end, we will have 7, for example, 7 or 9 or 10 fresh oocytes. And on the other hand, we have 7 or 10 oocytes that they have from a vitrified protocol. The results are the same. And we know that because we have studied a lot about that. It's very important because the vitrification has changed our way of work. At the beginning, when we started with the egg donation, and there are patients who travel overseas to come to our clinic to do the egg donation, and we only have 24 or 48 hours to advise the patient and to tell the patient that they need to come back, was very difficult to organize. It was very difficult to manage the egg donation program. The vitrification has changed our way of life. It is true that there are some patients and some donors or even patients that we don't know why is the reason, because the survival rate is low. We don't know why. It's true that in that case, the survival rate is fine. The results are the same. And we are very comfortable with the vitrification program because in our case, has changed our way of work, has changed our way of manage the patient. They are coming from another country, and we have the same results. For that reason, is under mask the survival rate. It's about 90, maybe 94, 90, 92, but it is true that we don't have a 100 survival rate. In that case, that we don't have so many oocytes that we hope, we need to do another things to be sure that the patient is going to have a good embryo transfer. But if we have the oocytes under the table and we have 11 fresh oocytes and 11 vitrified oocytes that we undo with the ICSI, the results are the same. So we are very comfortable with the egg donation vitrification program. We are very comfortable with the bank of the oocytes, because for us it's very, very important. What about synchronization or not synchronization? It has changed in the last time, because if we are using vitrified oocytes, we don't need to have patients with longer therapy with estrogens, about 30, 40 days under estrogens, with risk to bleeding, risk to decrease the implantation rate. With vitrified oocytes, we can do both treatment. We can use in synchronization or no synchronization, depends on the patient. If patients are living close of our clinic and we have a donor for them that could be compatible, both would start at the same moment, perfect. But if we can't do that and we need to use vitrified oocyte, doesn't matter. We personalize the treatment, depends on the patient, depends on the experience with another clinic, depends on the things that we need to focus, because there are some cases when the patient need to do the donation in only 4 or 5 days or maybe 10 days, because the endometrial is growing up early and we need to do the transfer early because in that endometrial start bleeding before another patient. We can do that. Doesn't matter. We can do whatever we want, whatever the patient needs to do the synchronization. For that reason, doesn't matter. We use not synchronization or synchronize. Depends on the patient. Depends on the things that they need to do the treatment. But there are no differences in the implantation rate in another aspects to that kind of preparation for the treatment. Another thing that we can do to improve not the quality of the embryo, to improve selection, the best embryo to the transfer, and trying to helping people to get pregnant in the first attempt, and to using the time-lapse. As you know, it's an incubator, then the embryos are inside. We don't remove the embryos in one moment. There are some camera, and depends on the time that the embryo divide, and depends on how the embryo divide, we can choose the best embryo to transfer. For that reason, it's very important, and we are using the time-lapse to helping us to choose the best embryo to transfer, the best embryo to frozen. If that embryos they don't have good times in the division, or good time when they do all procedures or they change the state, we decide not to do anything with them, no vitrification, not transfer them, because that embryos are not good. It's helping us a lot. As you know, in EV, we are working a lot of time with the time-lapse machines. We have embryoscope, EVA, a lot of time machines trying to helping them, the biologists, to choose the best embryo. As you know, at the beginning was a morphologic aspect to choose, to look under the microscopy, the embryo, and decide it could be A, could be B, could be C, could be D. Now with the time-lapse technology, helping us to choose the best embryos, and all these things are objective things. The time that the embryo divide, the times of some blastomeras appears, all these time are objective things that helping us to choose best embryo. I think that for us it's very important helping of this kind of technology to helping choosing the best embryo. Another thing that is very important for us is to transfer blastocyst embryo. We only do one blastocyst, and we only transfer blastocyst embryos, because we know that they have lower nuclear rate, lower excess of embryos, better pregnancy rate, and better embryo selection. For that reason, we only transfer blastocyst embryos, and in egg donation program, we try to transfer only one embryo. We know that for us, we have the best result for the patient if we transfer one embryo plus one embryo in another attempt, and if we try to transfer the two embryos together. It is true that for transfer, the patient could have more probably to get pregnant if they transfer two embryos. But for the patient, they have 20-25% to get pregnant with twin pregnancy. Now, in that case, we're talking about women about 44, 42, 43 years old. A twin pregnancy, it's a high-risk pregnancy. For that reason, for us, in our clinic, we are working, trying to convince the patient that the best option for them is try to do a single embryo transfer with blastocyst. And we are working all EV group and in Valencia, always working with single embryo transfer and with blastocyst. And here in this slide, try to show you all combinations are possible. We can use fresh Oocyte with fresh sperm to do a embryo transfer in fresh, but we can have the frozen sperm because the partner are living outside and they decide to frozen their sperm. We have a sample and we decide to do the treatment with the frozen sperm, and after that we can do embryo transfer with all procedure in fresh, but we can vitrify these embryos and we decide to schedule a now frozen embryo transfer in the future when the patient they would like to come. Or we can use vitrified Oocyte with sperm in fresh or frozen sperm to do an embryo transfer in fresh or vitrify these embryos, whichever is possible. For us, the best option is trying to use embryo transfer in fresh. It is possible, doesn't matter if we are using or fresh Oocyte with vitrified embryo. Doesn't matter. All options are good. All option is trying to helping people to get pregnant, but with options it is possible. Here we have the results. Okay, this data have been audited by a company who each year come to our clinic to be sure that the results that we show you in our web page are true. We are not telling lies. All that we showing you is the best result. And here is the truth, okay? Our pregnancy rates, our implantation rate, our twin pregnancy is lower than 30%. And probably in this year, the twin pregnancy was lower because we are working hardly trying to avoid the double transfer in the egg donation program. It is very important to remark, and if we do until 3 egg donation treatment, about 100% of the patients get pregnant. Only 2% of the patients after 3 egg donation treatment don't get pregnant in our clinic. So it's important, our pregnancy rate, but it's important that about overall of our patients achieve a child with the egg donation treatment in our clinics. And I think that that's all. Thank you very much for your attention. And now I'm going to try to answer your questions. Sorry if I speak fast and try to do it slow. And if you have any doubt, then try to repeat again because there would be some mistakes in my presentation. Thank you very much.
Thank you, Dr. Pilar. That was really, really nice to hear all about this. And of course, I guess we have lots of questions ready. So I guess let's begin with that. Okay, let me start with the first question. Here it is. It's from Caroline. Is previous diagnosis of ovarian cancer in recipient a barrier? It was 10 years ago. I have 1 ovary and my uterus still.
Hello, Caroline. Thank you very much for to stay here. If the oncologist allowed to get pregnant, there's no problem. It doesn't matter if you have had in the past ovarian cancer or whatever, but if the oncologist say that you can get pregnant, it's no problem for us. If you are younger than 50 years old and the oncologist say that perfect, you can get pregnant, it's not a problem for us.
Let me take a look at another question. Did I understand correctly that you can transfer embryo in a natural cycle without hormone therapy?
We can do that in some cases. For example, patients that they had they had a bad experience with the hormonal therapy, and they decide to do a natural cycles. We can do that. For example, people that they have problem with the parts or things. In that cases, in most cases, we use 35 for sites because we are not sure, and we are going to do when the recipient or the endometrial line it's okay. We have a donor for them, but we can use the natural cycle for the egg donation if the women has ovarian function, of course. If the patient embryo transfer in natural cycle, why not? It's an option. It could do. We use sometimes.
All right, thank you for explaining that. And let's see, we have another one. Do you have Skype consultation? I have tried to contact your clinic several times, but the coordinator says that I have to come in person to Spain. I appreciate that, but could you have a Skype meeting before the personal meeting?
We have that option. I am sorry by that, but it's true that my last two patients was on Skype. Patient overseas from States and from America, South America. So we have a Skype service for all patients. And maybe in that cases, you only come to our clinic for embryo transfer or to do the and to meet us to be sure that all is fine. But we have a Skype service for all patients, for national, international patients. Try it again. It's very important. Try it again. We have that service for all patients.
Okay, that's great to hear them. Sure. Okay, so I guess you can contact us. Okay, we are able to forward any questions to the doctor and try to arrange such a consultation. Okay, and let's move on to another question. I have read that success rate of live birth with egg donation is 50%. If egg donor less than 35 years old, is this true for recipients after 45 years old?
I read that the success rate of live birth with egg donation. I talked about that in 10 minutes ago. It is true that that the women older than 45 years old, they have a lower pregnancy rate than women that are younger than this age. But for that patient, is the only option to get pregnant, so it doesn't matter with that. But it's true that case, that women, they could have lower pregnancy rate in women older than 45 years old than women younger than that. But it's true.
All right, thank you for that. And let's see, we have another one. What is the success rate of egg donation in your clinic? Do you guarantee specific number of blastocysts?
I showed you in the last slide, but we are working with the number of the blastocysts now. Our guarantee almost two blastocysts. It means that we are going only one embryo transfer. It means for two transfer. But it's true that about 80% of our patients have more than 3 embryos. It means that they have maybe 2 or 3 transfers. So we guarantee 2 blastocysts. Almost to 2 blastocysts, but it's true that more than 80% of the patients have more than 3 embryos. That is true. We are working with that idea for you because it's confidence to be sure that maybe to get pregnant you have almost 2 blastocysts.
All right, thanks. Let's see another
Hello?
question. Do you do biopsy and PGT before embryo transfer in egg donation treatment? Hello, Dr. Pilar?
It's not allowed in Spain without any indication. We can do, but in that case, the sperm, it's
yes,
very...
we can hear you now, okay? But
Hola? Hello?
We got disconnected for a second, but it's okay now.
Yeah. Hello. No. Okay, perfect. We are... It's not...
Dr. Pilar? Hello?
Not allowed to do the egg donation, to do PGT in only in that cases that the man has a very there's a.
Hello, Dr. Pilar. Is it okay if you could just switch off the camera?
In that case, you can do that, but
it's
not allowed to do PGT.
Hello, Dr. Pilar. Can you hear me?
Young people.
Hello, Dr. Pilar. Can you hear me? Could you switch off the camera? So, because the sound is breaking.
We need to have some indication to do the PGT in that case. It's not in all patients, not in all age of the patient. You can do PGT, doesn't matter, but in our law, doesn't of the embryos. It's not a good idea.
All right, thank you. Thank you. Dr. Pilar, can you hear me right now?
Hello?
Okay, sorry, we had some issues.
Yes,
Is it okay if you could just switch off the camera? I think it will help here, okay, because the sound is breaking. So I want to make sure everyone can hear us. Could you switch off the camera, please? Super, thank you.
Yeah.
I hope now it will be better for everyone. Hope everyone can hear us. All right, so let me move on and present another question from Maria. So if the endometrium is more than 7 millimeters, how many days you have after to go ahead with the egg donation? Is there a time limit?
We know because we did studies in the past that women could be until 50 days, with estrogens. But in our clinic, patients usually are with estrogens about 25 years, no more than that, because we have a lot of donors. So in most cases, if patients come from another countries, because they have the programmation for the treatment of that days. No depends of us, depends of the patient. They start with the treatment because the menstruation are right before they hope, and they are maybe 20 or 25 with estrogen because they have the schedule or the planning for that date. But in our cases, patients that they are living here, maybe 20, 25 days, no longer than that. But it's true that we have studies that say that doesn't matter if you are even 50 days. No more than that, but even 50 days doesn't matter. But in our case, 20, 25 days. Depends of the patient. In most cases, depends of the patient because they have planned to come to Valencia, for example, the next week. It is true, the endometrial line is fine, but because they have the plan for the next week, we are waiting for the next week. But for that reason, in some cases, it's more than 20, 25. But in our cases, we don't have problem with donors, so it means that in 15, 20 days is the top of the days that patients are under therapy.
Okay, perfect. Thank you for that. And let's move on to another question from Fiona. Can the endometrium be too thick for a successful implantation?
There's a lot of publication that they talk that they have pregnancy with endometrial lines about 5 millimeters or maybe even 4 and 5 endometrial line, and they have pregnancies. And it's important to know why are the reasons, because the endometrial line is so maybe there's a problem, maybe it's a small uterus. First of all, need to analyze why is the reason, because the patient has this thick endometrium. As if all it's okay, the stereoscopy and all it's fine. You need to, in our opinion, try to get to do a transfer to be sure that maybe the patient could get pregnant. There's some therapies that could help in endometrium to growing up, for example, pentoxetilina, endometrial, vaginal estradiol part, some medication that could help in the endometrial to growing up. But we have pregnancy with endometrials, with thin endometrium. But first of all, need to analyze why is the reason, because that patient has this endometrium. If all is fine, need to follow in with the treatment and to know if or try to do the embryo transfer if for the patient get pregnant.
Thank you for this.
Hello?
I can hear you. We have another question. The references are from 2005.
Yeah,
Isn't
it's true that
newer research?
Yeah, we have newer research. The problem is there are not published in a publication, and we have our own research and our data that has been controlled by external company who say that it's fine. But because they are not in a publication, I don't show you because it's our own data. But it's true that we have improved our results in the last 10 years a lot. But it's true that I showing you publication that it's true that it's fine, but it's true we have best results, but I'm showing you the result that we have published in the past. So it's true.
All right, perfect. Thank you. Do you offer donor pictures or pictures of donor as a child?
In Spain, the donation is anonymous. It means that we know we take photos for all our patients, both donors and recipients, and we have in our health informatics system pictures of both. And the people who do the match know the pictures of donors and recipients, but we don't give any picture for anyone because in Spain it's anonymous. We can do that. Sorry, but in Spain we can do that.
Okay.
But we have recovered the patient. We have the picture of both patient and donor in our history, and people who do match know met the both. But it's true that patient can share the picture between them.
Okay, perfect for that. Thanks for that. I mean, for endometrial preparation, you state no more than 15 days of progynova. Why is this, please? I took 24 days for frozen transfer.
I talked about that before. Your endometrial line, it's supposed that with 10 days you have enough days to that your endometrial line or your endometrial growing up. It's enough with 10 days. Maybe there are patients that need that endometrial take more than days to grow, and in that cases we need to waiting for the endometrium. But it depends on the doctor, depends on another thing. But in our case, endometrial line is fine in 10, 12 days. We can do the embryo transfer without any problem. We don't have bad results in that cases. Doesn't matter. You need almost 7, 10 days. After that, the results are the same.
Okay, perfect. Thank you. And let's take a look at another question from Nicola this time. Would you recommend ER map after 2-flight egg donor transfer for next cycle?
I don't know what's ER map.
ERA map, I believe, or something like that. I'm not sure, to be honest, either.
Sorry, I don't know.
Sure, perhaps Nicola could give us some more information on that, and we can go back to this question, okay?
Okay, perfect.
I believe ERA test somehow. I heard ERA test, but
ERA. It could be ERA. Okay.
Yeah.
There's a lot of things that we can do before to do a new attempt with the egg donation. It's important to know the ERA, but it's important to know about the uterus, because there are some cases that it is very small uterus, the T uterus, and maybe with some hysteroscopy you can help in that endometrial to grow in better than before the hysteroscopy. That it's important to focus in the uterus. You can do an ERA, and you can do, for example, an hysteroscopy or things like that. Sometimes we need to change the donor because it could be to change the donor and you get pregnant. And to be analyzed, and the other thing that consider the implantation rate as fine. Thrombophilia, things like that need to be analyzed to be sure that there are no problems in the patient. but it could be, we can do this kind of proof, but it's true that we need to focus in the uterus to be sure there aren't any problem that avoid to get pregnant. We could do that.
Okay, thank you. Yes, I believe Nicola has explained it's endometrial receptivity array. Yes.
Yeah. We can do. We use this tool in that case is that the patient don't get pregnant after some fails with the egg donation treatment, but we use the ERA test and we use the hysteroscopy in some cases because there are some abnormality that you can use in the vagina, into the vaginal ultrasound, and maybe with hysteroscopy you can find some things that if you repair and you do a surgery that will improve the chance to get pregnant.
All right, thank you. And let's have another question from Sandra. What are the different kind of cycles for the recipient woman in egg donation program with fresh or vitrified blastocysts? Natural cycle with own ovulation or a hormonal injection of diaphyreline in a cycle before the transfer? What are the differences?
I'm going to study the question. Okay, first question. If we are going to do a normal cycle of the egg donation, it's suppose that first of all you are a woman under therapy and you have a donor and you can use fresh oocytes. In that case, you do a normal therapy, okay, and you can do the embryo transfer in about 20-25 days. In that case, is that the patient has the blastocysts and they have the frozen embryos, and that case is as a frozen embryo transfer. They prepare, by they know that they're going to do the transfer, and they know how many embryos they have and which one is the embryo they're going to transfer. The differences maybe could be in the results. If you are going to do a transfer in a donation or fresh or with vitrified oocytes, when you go to the transfer, you don't know really how many embryos do you have. If you are going to use a frozen embryo transfer, you know how many embryos you have. In that cases, we have the frozen sperm to use when with fresh oocytes, and when you do the embryo transfer, it's supposed that maybe you are less days under therapy because maybe with 10 days you can do the schedule. But depend of the program of the patient. In that cases that we are going to do a treatment in egg donation treatment, a normal egg donation treatment with fresh or with vitrified oocytes, we can use both. We can use antagonist protocol. It means that with the menstruation, the patient do a scan. If it's okay, patient starts with estrogen or starts with antagonist during 5 days, or we can use the classic protocol, and they do a vaginal scan in luteal phase to be sure that they have the corpus luteum, and if all is fine, they put an injection in the luteal phase, and then start with the estrogens with the menstruation. Doesn't matter. We can use all 3 types of treatments. The best one, or which is the treatment and which depends of the patient. If the patient has their vitrified oocyte, we can use the treatment that they will like. Depends on the planning, depends on the schedule, the travel. If they're going to travel the next week, or they would like to travel in 2 months, depends on the patient. But we can use all combination that I showed you before.
All right, thank you.
The differences depend on the planning. For us, considering the results, there are no differences. Differences of the logistic are more logistical problems and not dependent of the procedure of the patient. We can do whatever. Depends on the logistic of the patient and the planning of the patient. So we can use whatever. The patient who come from Canada, for example, and they have a sperm bank, we have a donor for them, we can vitrify these embryos, and when they come here, they come to an embryo transfer, a frozen embryo transfer. But if the patient are living in very close from here, in some cases, we call the patient, they come, and we do all in the same treatment. Depends on the patient, depends on the logistics of the patient, no depends on that.
All right, perfect. Thank you for that. And let's see another question for me too. Is PGT testing recommended if the recipient has had several natural miscarriages and is 45-year-old? Do you see more successes with the PGT testing?
Depends of the miscarriage. If the miscarriage was in the past with the round oocytes, I think that there are no indication to do a PGS. If all the miscarriage or the abortion was with egg donation treatment and they have failed a lot of times and the sperm is not very good, could be an option at the end, could be an option to do the PGS. But it's true that if the abortion was with the round oocytes, I think that there are no indication to do that. And if the women are older than 45, and we're talking about recipient, we are talking our age, our egg donation, our donor are younger than 35. So in that case, if the patient has a lot of abortion with egg donation treatment, it could be an option to try to talk about PGT, but in our centers, the indication of the PGT, it's very, we need to talk about them a lot of time because it's not easy to decide to do a PGT with the egg donation treatment.
Thank you for that. And let's have another question from Ilona. How important is it to match the blood type of donors? In my case, 0 RH minus.
Thank you very much for your question because that question usually asks me in another places. It is true that the combination of the blood type is more a social reason or ethical issue than no medical in all things about except the rate. We have patients that in your case seronegative. In that case, in your case, we always give you a donor as you seronegative because it's important that one thing is the social reason or the ethical reason. If you are A, your husband is 0 and we give you a B, there are no medical reasons because trying to avoid this combination, but it's important for all the results. If you are negative, in that case, it will give you a negative donor because it could be the isoimmunation considered to the rhesus type, and for us, that's important. So in the cases, we will use a seronegative donor for you. Doesn't matter the blood type of your husband or your partner, but we use in that case a seronegative.
All right, thank you. And for another one from Anita, is it wise to lose some weight before getting pregnant?
For us, we have studies that say that women with BMI more than 30, they have more probability to have abortions. For that reason, it's in that case, it is a recommendation to lose weight before to do the embryo transfer. So it's healthy for women, not only because they have more abortion, because in their pregnancy they have more problems, they have more diabetic, more premature delivery, more obstetrics illness in that cases. For that reasons, we're trying to avoid to do treatment in women with BMA more than 30, but in that case, we don't have any options. But try to explain them that they have more risk to have problems that they are a BMA slimmer.
Okay, thank you for explaining that. And what would you recommend after 3 failed cycles of frozen egg donation, including miscarriage at 8 weeks? From Erin.
It's supposed that if you have done all proof, it means that you have done an hysteroscopy, you have done an ERA test, you have done thrombophilias, all these kind of things. Maybe could change donor or could change the sperm. There are some publications who say that there are no effects, but we in a lot of cases there are some couples who have done a donation treatment with the sperm of their husband, the first cycle, second cycle, 3 cycles with different donors with the same sperm, maybe before to decide to give bye-bye to the IVF treatments and to decide we are going to adoption, try to change the sperm. Maybe in some cases, normal sperm with combination with the with another donor, we have good results with that. So before to say bye-bye, I try to look for a new combination with a sperm bank. Could be an option.
Okay, perfect. Thank you for explaining that. From Sandra, we have the next question. Are high doses of Proginova dangerous during the pregnancy? Is it necessary to take Proginova 6 milligrams a day after a fresh egg donation transfer? Why and for how long is it necessary to take it after a positive ACG test? It is said Proginova is strongly contraindicated during pregnancy.
It is true that if you read the prescription of any medication, you don't take anything. But it's important the Proginova because the endometrial line, you can do in a natural cycle if you are ovarian function, but if you don't have that, it's very important the Proginova and the progesterone because until the 12th week, the pregnancy or the estradiol or the progesterone levels that the pregnancy need to grow in are produced by the endometrium. After that, the pregnancy is starting to produce their own hormones, and their hormones are important to grow in the pregnancy, and that all work fine. But until the 12 weeks, we need that the patient take Progenova and progesterone to be sure that we are giving the pregnancy the hormonal levels to growing up. For that reason, it's important to take that. If you don't take anything, one option would be to do egg donation and vitrify the embryos. And for that, if you have ovarian function, try to do a natural cycle, a frozen embryo transfer with natural cycle. In that case, you are going to use only progesterone until week 8 week, and you are not using Progenova. So there are some options to do a treatment in that cases, and in some cases we use that. You do first you do the embryo frozen embryos with egg donation, and when you have the frozen embryos, then you schedule a natural cycle to do the embryo transfer, and you can avoid to take medication so many days. So there's alternatives to that kind of treatment.
Okay, perfect. Thank you for that. Prior to embryo transfer, do you perform any blood tests? How many days progesterone does the recipient have before transfer?
Now we are doing a study in Valencia that we are doing a blood test to establish which the cutoff in the progesterone levels to know the best option to get pregnant for patient, but it's in a study context. And now after the result of that study, I could share with you our experience to know if it's important to do a blood test before the embryo transfer. In our cases, we in our patients take 10 doses of progesterone. It means that they start the day of the donation in the afternoon with progesterone. That doses means once, 2, 3 the day of the fecundation, 3 and 4 day 2, 1, 2, 3, 4 and 5. Day 3, 6, 5 and 6, day 4 until 10. It means that the day that we are going to do the embryo transfer, patient has taken 10 doses of progesterone, and that we change the way that the patient taking progesterone, and we improve our pregnancy and implantation rate with this 10 doses of progesterone.
Okay, thank you for that. Let's see. How long after the endometrium of the recipient reaches 8 millimeters can you keep the recipient waiting for the fresh donation? After the endometrium is 8 millimeters, can the recipient wait another 2 weeks for the transfer taking Progenova?
Depends if the patient until 50 days, the patient could be with progenova. But it is true if you have an endometrial on 8 millimeter and you don't have donor in the next 2 weeks. In our case, we repeat the anyway scan in 1 week, maybe 10 days to be sure endometrial line is trilaminar and all it's fine. Okay. In our clinic, in most cases, patients are more than 20, 25 because they have the planning to come that day, and in that cases, then they need to wait. But we have data. We know that you can be with estrogen therapy until 50 days, and there are no impact in your results. But it's true if you need to wait 2 weeks more. In our case, in our protocol, we repeat again a new scan in 1 week, 10 days to be sure endometrial line continues following perfect and there are no impact in your chance to get pregnant.
Okay, thank you. I was told that the ERA test was only accurate for the month that it is taken in. The clinic does not recommend it. What is your professional opinion? Can it help implantation, please?
Thank you for your question. We have studied that, and in IVF Valencia we did the first study with the ERA, I think that maybe 5-6 years ago. And I was one of the authors of that papers, of that publication. And we analyzed in some patients, we repeat the ERA, one on the moment of the study, and in some patients, we repeat the ERA 2 years later to be sure that the results was the same in the same patients. And we analyzed them, and we had the same results in the same patients. So the patient A in 2006 was one ERA or 2008, but 2 years later, the ERA was the same. So the results are consistent between more than 1 cycles. We're talking about 2 years later. 1 cycle or even 4 or 5 cycles, the result must be the same. In our cases, we do the ERA in 1 cycle, and we schedule the embryo transfer maybe 3 or 4 or 2 cycles later than the ERA test. So we suppose that these results could be the same later, maybe 2, 3, 4, 5 months later than the month that we perform the test. So we use the ERA 1 test and we do the transfer later, so the results are the same. So we think that they are safe, and in our cases, we have the same results.
Perfect. Thank you. Yeah, you would like to add something? Sorry.
Yes, I would like that it could help implantation. In some cases, I don't know how many of the patients that we have an EV have a ERA test abnormal, where the implantation window of implantation has changed or has moved from the normal way. But I think that it's about 20% of the patient. In that 20% of the patient, if we didn't know the ERA test, we can do always the same. We can change the sperm, we can do PGT, we can do a lot of things that maybe only to add more or trying to remove 1 dose of progesterone, we can helping that people to get pregnant. So the ERA test could improve the implantation rate if you finally has a window of implantation for your normal way. So there are 20% of patients of the ERA test could help in them to get pregnant or to improve the implantation rate.
Okay, thank you. And let's take a look at another question. For Maria, any other treatments, any specific diet before egg donation with donor eggs?
There's a lot of people talking about the diet, that the diet could be bad or good for a lot of things, for avoid cancer and a lot of things. I think that if you are a healthy woman and not smoke and your BMI are fine, I think that is very important. And you don't have anxiety, don't have stress, and you do sport with regularity, helping your body to be a healthy people and trying to improve your chance to get pregnant. but I don't have a miracle diet to give you. To say you take broccoli with rice or you eat paella, you will have more probability to get pregnant. We don't have that, but it's true that all people say that that if you are a healthy woman, you have more probability to get pregnant. It is true that we have patients that are very worried about what they are eating by smoking a lot, or they are always worried. So I think that it's important to be sure that not to smoke, healthy life, sport, anxiety, all these things are good, or trying to avoid the anxiety, all these things are good, trying to improve your life. And if you improve your life, you improve your probability to get pregnant.
Okay, perfect. Thank you. Is adenomyosis a problem with pregnancy rate?
Adenomyosis is a bad box. It's I don't know how to say, but adenomyosis depends on adenomyosis. Depends if they are affecting the endometrial line. Depends if the adenomyosis could have endometritis, because there are some cases that adenomyosis could go to endometritis. In that case, you need to analyze and to do hysteroscopy to be sure that there is no problem concerning to the uterus. But I know that in that adenomyosis, maybe the implantation rate could be lower than in another patients. But if you give in that patients, you use the generate analogous to the before the estrogen therapy could help in them. But we have pregnancy with adenomyosis. Growing up fine. If the quality it's normal, patient will get pregnant without any problem.
Okay, perfect. Thank you for explaining that. From Sandra, another question. Can we do the fresh or frozen embryo transfer on a fresh cycle without blocking the ovulation? What is better, to block the ovulation or not? If the recipient ovulates and after that has the transfer, does it mean her body is producing own hormones and can take less estradiol pills after the transfer?
We sometimes use the both fresh or frozen embryo transfer without analogs, with a generate analogous. We can use that. The problem in that case is that must be sure that there are no ovulation, because in that case, if you ovulation, the window of implantation could move, and when you are doing the embryo transfer, you don't know really if the implantation is in the best moment, if the patient has their own progesterone, and could change the implantation rate. So if you would like to do a hormone therapy treatment without analogous, you can do that. In the end, there are some reviews in the Cochrane, for example, who say that the results are the same, but you need to do a scan frequently to be sure that the patient doesn't have any ovulation, because if the patient has an ovulation, could change all the endometrium. It is true that maybe you can ovulation if you need to use less medication. If you would like to do that, the best option is to do a natural cycle. But in that case, you have a donor with fresh or vitrified oocyte, you can do it with vitrified oocyte with any problem, or you can do a frozen embryo transfer before, and with the embryos frozen, then you do a natural cycles, and you are not to worry about the donor, or to worry about the oocyte retrieval of the donor. But you can do that. If you would like to avoid the therapy, you can do in a natural cycle, but you can do with fresh oocyte. It's more difficult, because you need to do the schedule, a perfect schedule with the donor, and we can use vitrified oocytes, or you can frozen it before, frozen them before, and then you schedule a natural cycles. You can do that.
Okay, thank you for explaining that.
But it's not good to do a hormonal replacement therapy and try to waiting for a natural ovulation to avoiding the medication. It's not good, because if the ovulation started before you think, the endometrial line start to change before you think, and you are doing the embryo transfer, not the best way for the endometrium. So you decrease the probability to get pregnant. So it's not good. Maybe it could be helping you if you schedule them, but if you are waiting for that the patient has a follicle to ovulation, it's not good for the cycle because there are some things that you are not going to control and maybe could improve could start the rise of progesterone before you hope and do the transfer later than you do in normal way.
Okay, perfect. Thank you. And from Maria, we have another question. After having the transfer of the egg, any recommendations? Stay in bed or stay in the hotel for 1-2 days to make sure the egg is secure, or any other recommendations?
We did a study, I think that 4-5 days ago, and we divide patients into groups. One of them stay in the bed, and stay in their room maybe 30 minutes, and the other half of the patients, they finish the transfer and they come back their room walking and they dress and say bye-bye. And we had the same results. For that reasons, we have changed our protocols in Valencia, and the patient don't stay in the clinic. The patient do the embryo transfer as an insemination, and we don't give them any special recommendation after the egg donation treatment and the transfer. And most of them take a plane to come back their countries, and we don't give them any special recommendation after the embryo transfer.
Okay, perfect. Thank you. Do you have advice for high natural killers except for intralipids?
I don't have information about the immunologic aspect. It's not my topic. I don't know. I don't have the answer of that question. Sorry very much, but I could try to answer later with some studies, but now I don't have information. I can't answer that question. Sorry.
Not a problem, of course. Yoshiko, you can actually contact us via patient@eggdonationfriends.com. We can definitely forward this question as well to the doctor, and we will be happy to get back to you on that, okay?
Thank you.
Okay, and in the meantime.
Okay.
The positive ACG test and taking 6 milligrams Progenova into 1,200 milligrams of utrogestan, is it important to test the estradiol and progesterone levels? How often? I have heard the progesterone test should be done, but nothing about the estradiol level test during estradiol test, not necessary when taking in pregnancy. Progenova 6 millimeters, right? Milligrams, sorry, daily.
I think that it's necessary to do these progesterone levels when a patient gets pregnant. Suppose that the pregnancy and the medication that they are taking, it's enough to have good levels. In our case, we study the hormonal levels before the embryo transfer, overall if there are any rising of progesterone before the transfer, and it's a premature luteinization that it could move the window of implantation, and it could change the probability to get pregnant. After the pregnancy test, we don't use any blood test to know anything, not hormonal levels, anything. I have heard a progesterone test should be done, but nothing about estradiol in the first week, 2 weeks. We don't use the progesterone and not estradiol levels when the patient gets pregnant. We don't have we think that it's not important to the evolution of the pregnancy at this moment. Estradiol test or progesterone test important during the treatment before the embryo transfer. I think that it could help in you if you don't have a perfect endometrial line and the estradiol levels are lower than 60. You say something is that patient, maybe we're going to change the way of administration of the route of administration of the estradiol, and maybe we change could achieve better levels. So in that cases, we are using before the transfer. After that, we don't use the hormonal levels to anything.
All right, thank you for this. And I have another question. Do you do uterus scratching for Mercy?
We are doing now a study about that because there's a lot of controversy about scratching, and we don't have the results. But in our group, we thought that the scratching doesn't have any impact in the implantation rate. But now we are doing a study in egg donation treatment, a randomized clinical trial, to be sure, or to trying to answer the question if scratching is useful or not useful in the egg donation treatment. Now I don't have the answer.
Okay, thank you. Of course, that's okay. As I said, anyone, you will be able to send us the email to patient@eggdonationfriends.com. We will definitely forward the questions to the doctor, and then we can get back to you on that as well. Okay. Let's have a look. We will be slowly finishing, but I do see we have a few questions left, so let's just answer them, and we can.
Okay.
We will be finishing slowly. Let's take a look. Could you explain what the implantation window means? How is it determined, and can it be extended for a longer period with the medication?
Okay, I'm going trying to explain what's the implantation window. Suppose that our uterus, okay, our uterus is not always have reception to embryos being implanted. I'm going to say it again in another word. Okay, the uterus is not an embryo. It could an implantation in any moment of the cycle. Okay. The moment of the endometrium has the best option to recognize an embryo is the window for implantation. Suppose that it happens in a normal way about 1 week later the ovulation moment. Okay, ovulation at 14 days, more or less, in a regular cycle. It's supposed that the window for implantation starts more or less between 21 24 of the cycles. Okay, this is the moment with endometrium is receptive. It means that there are an embryo near the endometrium and the uterus. Endometrium and the embryo could start some conversations, and then the implantation happens. That window of implantation, it knows now that sometimes in some patients happens 44, 21, 24, or later, 24, 27. So the medications not move the moment of the implantation. The problem is some medication, the progesterone, is the medication that try to open the window of implantation. So there are patients that need to take more progesterone, trying to move the implantation rate in the moment that you are doing the transfer, because you are doing the transfer 5 or 6 days with it's a blastocyst. It means that we are using some drugs, some progesterone, trying to synchronize the embryo development, the blastocyst development, with the endometrial line. For that reason, we use the progesterone. At the beginning, we thought that the window for implantation was always the same. 21, 24 days of the cycle was the implantation rate. But now we know that that's not true. That patient that has the window for implantation in the 18, 21, and another patient has later. To know or to start to open the window for implantation, we use progesterone, and to do it later or before the progesterone. For that reason, we use that kind of dose. I don't know if you understand my answer, but the idea is trying to explain in a normal vocabulary what the window for implantation means.
Okay, sure, of course. Well, as I said, we will be able to just check it again and send it if you'd like, okay? So you can get back to us and we can help you out, of course. All right, and I believe we will have our last question for today, okay? It is from Maria. Any acupuncture treatment would help before the transfer?
There's some studies who say that some procedure, acupuncture or other things, are trying to improve the vascularization of the uterus, would improve the implantation rate. So there are patients. So there are clinics that they had included the acupuncture treatment in their service of the patients, because they have the space and maybe trying to improve the vascularization. We don't have experience with the acupuncture to offer to all patients, but there are patients that they believe in the acupuncture, it could help in them. But it is not a normal practice in our clinic. But there are patients that they did and they do and by themselves and their home or in a hospital or in a hotel or whatever, and could help in them, but we don't have enough results to conclude that acupuncture could help in all patients to get in to get pregnant. We don't have enough results.
All right, thank you. Okay, super. Thank you for explaining that. Lots of actually patients ask us about that, so thank you for for letting us all know. All right, I believe that we have all questions answered. So thank you everyone for so many questions. We really are happy that you are connecting with us as well. And thank you, Dr. Pilar, for helping us out here as well. Okay, would you like to add anything, Dr. Pilar?
No, thank you very much to stay here and at that time and connected with trying to learning or trying to know more about the egg donation. Thank you very much for giving me the opportunity to share with you our experience. Sorry, some of my answer or my question is not clear, and I will try to explain it better in the next time. And thank you very much to share and to stay connecting at that moment, at this time. See you soon.
Yes, super. Thank you for that again. And of course, everyone, if you have any other questions or you would like to get in touch with the doctor, please, you can always get back to us via patient@eggdonationfriends.com. We can forward all your questions. And of course, if you're looking for a clinic or anything you have issues with, you have some queries, also you can get back to us. We will try to help you out as much as possible. Thank you again, and hopefully we will see each other next time. Thank you so much. Have a very good night. Bye.
Very good night. Bye bye.
Bye bye.